What if I told you that a single electrical stimulus near the eye can tell you whether the problem lies in the brainstem, in the facial nerve, in the trigeminal nerve, or even the multiple sclerosis? Sounds complicated, right? But by the end of this video, you will understand the blink reflex so clearly that interpreting it will actually become very easy. Hello everyone, I am Kushi Thakkar, neurophysiotherapist, and welcome back to the EMG-NCV Clinical Series. So if you have ever been confused by R1, R2, ipsilateral, contralateral R2, the pathways, the lesion, the localization, and the interpretation, then this lecture is exactly what you needed. So I'll explain in this lecture what is blink reflex, complete neuroanatomy, testing procedure, normal waveforms, clinical significance, pathologies, lesion localization using blink reflex, common abnormalities, practical interpretation tips, and high viva points. So everything is explained step by step with proper diagrams and clinical examples. So without wasting time, let's begin. So the electrical corneal reflex, the blink reflex is the exact electrical correlate of clinically evoked corneal reflex. So as we had discussed in the late responses slides where your S1 ankle jerk resembles your H reflex, it's a clinical correlate. Similarly, so how do you check your corneal reflex? You take a cotton wisp, you put it, you just touch with it to the cornea, and if the patient blinks, you say it is present, right? So that is how the pathway. The electrical pathway gives us the electrical correlate. So now let's understand this. So this is the peripheral, that is cranial nerve 5, trigeminal, and cranial nerve 7, that is facial. Once the stimulus is given, then that goes to the central nucleus that is situated in the pons and medulla, and then you get the diagnostic output. So clinical to electrical measurement is your blink reflex. So a true reflex, unlike F wave, it contains a true synapse featuring an afferent sensory limb. There is an afferent pathway, there is central interneurons, and the efferent motor limb. That's why it's a true reflex. Blink is a reflex. Now, diagnostic utility, what does it help us to understand? So, it detects any abnormalities along the entire pathway from your sensory stimulus, that is your receptors, to your afferent, to your interneurons, to your efferent, and the outcome. So, wherever in the localization of lesion is helpful along the entire neurological pathway. Peripheral mate will help you understand trigeminal nerve, facial nerves, and central mate will help us understand if there are any lesions in the pons, medulla, beat, any tumor or multiple sclerosis, demyelination, compression, infarct, etc. So the pathologies which we basically target to which we can address using blink reflex include compressive lesions, as we said, tumors, SOLs, then brain strokes, multiple sclerosis, Bell's palsy, and demyelinating polyneuropathies. Now let's understand the actual pathway of the blink reflex. So this is one diagram, and this is one diagram which I refer usually, a small flow chart. So I will just explain from the flow chart and then the actual diagram. So see, there is the afferent stimuli which you give. The afferent stimuli is given at this location. I'll be showing it in a proper diagram. So you stimulate basically the supraorbital nerve. Ipsilateral stimulation of the supraorbital nerve. For example, you are stimulating a right side. So that is going to go to cranial nerve nucleus number 5, because you are stimulating the supraorbital branch of trigeminal nerve. As we know, 3 branches of trigeminal nerve are present. From that, cranial nerve nucleus 5. Now, cranial nerve nucleus 5 I represent with a circle, the filled solid circle, and cranial nerve nucleus as a regioned diagram of a rectangle shape. So, cranial nerve nucleus 5, again it goes to 2. First is the main nucleus which is situated in the pons, and the other is the spinal tract nucleus which is situated in pons and lateral medulla. Now these two, from the pons, that is main nucleus, the stimulus which comes out to the ipsilateral facial nerve is called as R1. So ipsilateral trigeminal nerve, pons, and then ipsilateral facial nerve nucleus, that is your R1. Now the stimulus that goes to spinal tract nucleus gets divided into two stimuli which come as R1 and R2. So this is both are R2. R1 is ipsilateral, which came from the pons. Now from your spinal tract there are two R2s. One R2 goes to ipsilateral facial nerve nucleus, and the other R2 goes to contralateral side, where your R1 was coming from your pons. Okay, this diagram is easy, understandable. Now, so basically, now let's understand from this diagram. So, afferent, that is input, is mediated by the supraorbital branch of ophthalmic division of the cranial nerve nucleus 5. Then it goes to the main sensory nucleus, that is in pons, and spinal tract nucleus situated in pons and lateral medulla. This, the central processor is, that is the synapse where occurs. That's why it's called as a reflex. Mid pons, that is main sensory nucleus, and lower pons medulla nucleus of spinal tract. Both of these go to the facial nerve. Now here the V1 directly went to the ipsilateral part, this ipsilateral part, and the efferent, that is the, this second diagram, the yellow part goes to R2 ipsilateral and R2 contralateral. Okay. So if you understand from this, it's well and good. If not this, so the blue one is the stimulus. Now this is basically the stimulus to the pons. This part of our flow chart, it is going, blue part is going to ipsilateral side, again R1, this part of the chart. Now this yellow part, which is going to contralateral R2, and here ipsilateral R2. So basically you have R2 on two sides. A quick R1 and R2 discussion again. So R1 component is the early response. When you stimulate, the first component which you get is R1. This is important because later you have to clinically correlate the time difference or the latencies for the pathology finding. So let's focus this. So R1 is the early response. R2 is always the late response. Why? Because here directly V1 stimulus supraorbital nerve, then pons, and then stimulus aega at the facial nerve ipsilateral one. Okay, so pathways pons, ipsilateral facial nucleus. Circuit is disynaptic and output is ipsilateral only. Wave features, it is fast, it is stable, you can reproduce it again and again, and it is typically biphasic or triphasic in waveform. Now R2, the pathways from your V1. Since the pathway is complex, response is going to be late because, so here again V1, that is your stimulation. Now it's going to spinal tract nucleus, that is medulla and lateral medulla and pons. Now there are interneurons, and then it goes, so here this is the spinal tract nucleus, then interneurons, and then R2, two types of R2, one is ipsilateral, one is contralateral to facial nerve nucleus, so bilaterally. So now this circuit is a multisynaptic circuit because we know there are so many interneurons involved, and the output is always going to be bilateral, that is you get ipsilateral and contralateral response. That's why the waveform is again slower, it's variable, and it's polyphasic. It's, that is how it like readily habituates, adapts with the repeated stimulation. So that is why it is not reproducible as compared to R1. Now the good to know part. So this is the basic diagram which you should remember for where and how the electrode is placed. So recording bilateral orbicula oculi muscle, G1 is the active electrode which is placed below the eye, lateral and inferior to the your mid pupil. G2 is the reference electrode which is placed as the left canthus, and ground is placed at the mid forehead or chin to complete the circuit. You stimulate at the supraorbital notch here, that, or you call it as a superior orbital fissure, which you have studied in your anatomy in your skull, and then it is like little medial to the eyebrow. Now machine settings, it is just good to know. So sweep is set at 5 to 10 meter per second division. Sensitivity is 100 to 200 micro. Now this is just good to know part. So the stimulation protocol, as you see on the screen here, this is R1 which has a shorter latency, then comes your R2, and these are superimposed. So basically we capture 4 to 6 waves and then superimpose them to determine the absolute shortest response latencies, and to stimulate and to find this we apply a supramaximal stimulus ranging between 15 to 25 milliampere from the base of 0 milliamperes, and the normal output which we should get is a single unilateral stimulus yielding an ipsilateral R1, because that comes via the pathway of pons, main sensory nucleus, and an ipsilateral R2, and the contralateral R2 which comes via the pathway of pons and lateral medulla via the nucleus of spinal tract. Then our diagnostic cutoffs and normal values. This is a must know part because this is the one which is which is going to help you to interpret your reports while you read. So first is R1 ipsilateral. We know the pathway is shortest, so absolute latency is going to be short. It is less than or equal to 13 milliseconds, and you stimulate always two sides, that is the right side supraorbital nerve and get the entire results. You also stimulate the left side supraorbital nerve and get the entire results, and then you compare R1 bilaterally. So the maximum side to side difference should be less than or equal to 1 by 2 meter per second, milliseconds. Sorry, excuse me for that. Then comes your R2. So ipsilateral R2, again the absolute latency is to be less than 41 milliseconds. So that again comes as a straight pathway from spinal tract to your ipsilateral facial nucleus. So that latency is going to be shorter than the R2 contralateral because it has to pass to the opposite side facial nerve nucleus. So absolute latency there is less than equal to 44 milliseconds. And similarly, the difference less than or equal to 5 milliseconds, and for R2 contralateral, the both side difference is to be less than equal to 7 milliseconds. So you have to always remember that R1 latency marker is placed where the potential departs from the baseline, and R2 is marked at the shortest latency among the superimposed traces, as you saw in the previous graph. So this is very important, the localization of the lesion. So this is the diagram which I told you I have referred for my studying. I hope this helps you too. So if there is, let's come to the diagnostic now. So afferent lesion, cranial number 5, trigeminal nerve lesion is there. So since your afferent, that is ipsilateral stimulation to supraorbital nerve and cranial nerve nucleus, here itself the lesion is there, आगे का pathway is not going to respond because incoming ही नहीं है, there is not going to be any outgoing, right? So you won't get R1 ipsilateral, you won't get R2 and R2 contralateral as well here. Okay, so they are going to be either delayed or absent depending on what type of pathology and what stage of pathology it is. But when you, this is for the right side, for example. So now if you stimulate the left side supraorbital nerve, left side का cranial nerve nucleus 5 तो normal है ना. So you will get all R1, R2, ipsilateral, contralateral, unaffected side is normal. So these will be normal. Now, this is your incoming part, efferent part. Now, if the lesion is efferent, that is your facial nerve nucleus lesion is there. So now, because the output is affected, wherever you stimulate, abnormal side का result आएगा ही नहीं because the nucleus itself is affected. So no output you will receive. So the defective side and the recording side. Responses are delayed or absent only on the abnormal side of the face, regardless of which side is stimulated, right? Now comes the central lesion. So this actually here now wherever your lesion is, depending on that you will get mixed patterns, and then you can determine whether the lesion is in mid pons or medulla depending on what waveforms you see. We'll understand the peripheral lesions in the next slide. The most important part, that is our peripheral lesions, localization of the lesion. So if your stimulation on the affected side, this is stimulation on the unaffected side, and the results for trigeminal nerve both and facial nerve both. So first is our trigeminal lesion, stimulation on the affected side. For example, your cranial nerve nucleus of this side is affected. If you stimulate this entire pathway beneath it going via the main nucleus, spinal tract nucleus and the stimulus, everything is going to be blocked. So you will get absent or delayed R1, R2, ipsilateral and contralateral all. Now stimulation of the unaffected side. So now this cranial nerve nucleus of this side was affected, you got no response. Now if unaffected side is stimulated, its entire pathway is intact, right? Its main nucleus, spinal tract nucleus and the result. So you will get both stimulus, all the normal R1, R2 and R3. R1, R2, ipsilateral, contralateral. Next comes your facial nerve nucleus of any one side if it is affected. For example, this side is right side is affected. Okay. So right side may say you will get one R1, you will get R2, one and one contralateral R2, right? So since your facial nerve nucleus itself is affected, you will be having absent or delayed R1 and R2, but your contralateral R2 is going to be normal. Whereas now when you are doing this on the unaffected side, okay, so the unaffected side facial nerve nucleus is not affected. So your R1 and ipsilateral R1 and R2 both are going to be normal ipsilateral, same as this side. Okay, but now again your R2 contralateral is going to be affected because you are stimulating the unaffected side. So that is going to be delayed. Now we have understood about the peripheral lesions, coming to the central brainstem lesion. So first is we have two nucleus of the cranial nerve number 5, that is midpointine lesion. Now if the main sensory nucleus is affected, it gives out the stimulus as R1. Okay. Now the other contralateral and ipsilateral R2 is given by the spinal tract nucleus. So if your same side is affected, the main sensory nucleus is affected, all that is going to be affected is absent or delayed R1 only. R2, ipsilateral and contralateral are coming from the spinal tract nucleus. So those are going to remain normal absolutely, right? So this tells us that the lesion is absolutely exactly inside pons. So it can be a pontine stroke, NSL, SOL inside the pons, or MS or any structural lesion. Now we move to medullary lesion, that is the spinal tract nucleus. And if that is affected, that was giving us R2 ipsilateral and contralateral. But R1 was intact, right? It has been given by the pons. So stimulating the affected side is going to give us normal R1, and from the same side we get normal R2 contralateral, but absent or delayed R2 ipsilateral. Okay, so now there is one more thing which we have to remember is if the lesion is very extensive, both R2 ipsilateral and contralateral are going to be delayed or absent because both R2s are being given by spinal tract nucleus. Otherwise, R1 is going to be normal, absent R2 contralateral, and normal R2 ipsilateral. Coming to polyneuropathy and demyelination. So the polyneuropathy, so demyelinated now we know demyelination causes the loss of the protective covering, the myelin sheath. So signals get leaked around in the surroundings into the plasma. So the leakage is going to cause slowing of the conduction velocity. So there will be all the stimuli, for example, in GBS. So all the potentials will be present in the initial stages, but they are going to be delayed definitely because there is no saltatory conduction. So R1, R2, ipsilateral, contralateral, all delayed. Later, in a chronic lesion or in a severe lesion, they can be absent as well. This reflects severe slowing across the proximal sensory pathways. This is your demyelination. Next is your axonal lesion. So in axonal lesions, we know that since the axon is affected, there is going to be polygon degeneration and regeneration. But we also know that this happens more in the distal areas. And we also know that the blink reflex is mediated mainly by the proximal pathways of the facial nerve and the trigeminal nerve. So these neuropathies actually rarely affect the blink reflex because they are mediating the proximal part and they are spared in early distal axonal lesion diseases. There are certain technical errors and pitfalls for which we shouldn't fall and misdiagnose. So that we have to be aware of the habituation because we know the R2 gets habituated because it's a multisynaptic pathway. So R2 potential disappears if stimuli are delivered too quickly. So you must wait several seconds to avoid adaptation between the stimuli, and you shouldn't use continuous repetitive stimulus. R1 doesn't get adapted. It is reproducible and repeatable. R2 isn't. Please remember the difference which we have discussed earlier. Next is you have to manage the muscle tension. The patient must be fully relaxed. Muscle tension generates signal noise, which will again superimpose and obliterate the R1 and R2. So those are the pitfalls, the extra noises which overpower our biological signals. So we have to use machine audio feedback to help the patient relax their face. That is your biofeedback. And then we have to prevent stimulus artifacts. So ensure the ground electrode is firmly placed. Build stimulation slowly from 0 milliampere to avoid unnecessary patient discomfort because excess stimulation causes skin irritation and artifact interference. So these are the exam points which you should remember for your CET definitely, and also for your clinical postings, reading interpretation. So R1 is disynaptic, comes out from the pons only and is stable, is reproducible. R2 is multisynaptic, pons plus lateral medulla. It is variable and it habituates. That is why it is not reproducible, and we have to give enough time between the two stimuli. Cranial nerve lesion 5, if that is affected, that is the main nucleus, which is going to give the entire pathway from our diagram. So all responses are going to be delayed or absent when stimulating the affected site. Cranial nerve 7 lesion, that is the efferent output is affected, then all the responses are delayed or absent when recording the affected side of the face because that is the output. Essential diagnostic tools for multiple sclerosis, brainstem, strokes, Bell's palsy, and GBS is your blink reflex. So, hey, congratulations if you have reached till this point. Means you have understood the most important pathways of blink reflex. So, blink reflex is actually very easy provided you understand the pathway. So, always remember the diagram which I have explained to you. Maybe you can, modify it or formulate it in the way you remember, but that is the basic structural framework which will help you remember the pathway. Once your pathway is remembered, any lesion, any side stimulation, and the results you know very well. So yeah, if you found this useful, please do like, share, and subscribe this video. Share my channel to your friends if you think they're going to get any benefit out of it. And yes, I am running a mentorship program where I want a very sincere and actually students who want to study, learn more with your enthusiasm and your curiosity. Because here what we do is make concepts easy, work on clinical based reasoning, and that's how we understand our clinics, not only theoretically but also practically. So if you want any details about it, you can just drop down your comments or just check the description box and I shall reach out to you. And yes, I'm reading all your comments. So if you want me to uptake anything in the next lecture, please drop down in the comments so that I can plan my lectures accordingly. Keep growing, keep learning. All the best. Thanks for being with me throughout the lecture.